From a management point of view, again, I've explained how important it is to discuss with the patient and the family and the multidisciplinary team. One thing that we used to do years ago was regular toileting, and then it became out of vogue, but now regular toileting is a really good way of trying to improve people's continence. And even if it means, you know, every hour and a half to 2 hours asking somebody who needs to go to the toilet, it's a really good way of getting somebody continent again rather than them being incontinent. Obviously, we try and avoid telling the patient, well, I'll be back in 2 hours to put you on the toilet, because straight away they're clock watching, wondering, well, that 2 hours is nearly up, I'm due to go to the toilet. So a couple of times a shift, it's worth going over to somebody who is continent and asking if they need to go to the toilet. It's important to treat any underlying cause, so to get rid of any infection and to get rid of any unstable diabetes, and that will hopefully help with continence. Obviously, put bottles in easy reach, and if somebody does have communication problems, make sure they've got a communication aid so they can get in contact with somebody to help them go to the toilet. Remove any of the exacerbating factors, like I've said. If someone has a high blood sugar, if you bring that down, their thirst will improve, and so the amount of urine that they're passing will improve. Bladder retraining is really important. Bladder retraining, particularly for things like nighttime enuresis in children who wet the bed, it's a very similar thing for someone who has an urge incontinence. So somebody who can't retain an awful lot of urine, if you try and encourage them to drink more, particularly during the day, not necessarily in the evening, then the likelihood is they'll train their bladder to be able to take more and more fluid. So instead of reducing fluid and to stop incontinence, increasing fluid, and it'll train the bladder to be able to retain more urine and hopefully improve their urge incontinence. So that's another way of helping. And then there's the drugs which are the anticholinergic drugs, which you may have heard of, such as oxybutynin. And these, as I said, the fibres around the muscle around the bladder, the detrusor muscles, what the anticholinergic drugs do, they stabilise it, so they make it become less hyporeflexive or hyperreflexive. They don't work all the time, but they can work very successfully. So as somebody who's got an urge incontinence, trying these type of drugs will reduce the amount of urge they need, and they can retain more urine in the bladder and reduce incontinence. Indwelling catheters should be avoided at all costs. So if there's an indwelling catheter there, unless it's there for a specific reason, they shouldn't be used. Indwelling catheters shouldn't be used to manage incontinence, okay? First of all, if somebody's incontinent and you put an indwelling catheter in, there's no way of knowing when someone regains their continence, because they're not being able to retain any urine in the bladder. As soon as urine's made, it's just draining straight into the catheter. So that's the first reason. Second reason is it will lead to further complications. So the likelihood is it's going to lead to a UTI. About a quarter to a third of our patients will get a UTI anyway, but by putting a catheter in, you're going to significantly increase their risk of getting a UTI. So avoid catheters at all costs, and where you see them, unless there's a specific reason and rationale, then they should be removed. Obviously, for things like retention, we can consider intermittent catheterization. There's very little evidence for how to manage retention, but one way is to, rather than put an indwelling catheter in continually, just pass a low-fric or an intermittent catheter maybe once or twice a day, just to get rid of the urine that's there, and then remove it, and then someone can go to the toilet normally, hopefully in between. Obviously, they've indicated for specific reasons, if someone's at high risk of pressure sores, or if they've already got a pressure sore, as I mentioned before, urine will affect the skin's integrity and possibly worsen a pressure sore. If there's acute fluid management needs to be monitored, so if we really need to keep a strict eye on their fluid management, then we might need to put a catheter in, or if it's going to affect their long-term management. So if someone's life is significantly being affected by the fact that they've got an urge incontinence and the anticholinergic type drugs haven't worked, and it's significantly having an impact on their life, then it may well be that we'll consider using a catheter if that's going to improve their quality of life and their function. So they are used sometimes, but we try and avoid at all costs, particularly in the acute phase. We will get rid of catheters, even if they're, as they become non-necessary, and we can either try with that catheter by just removing it, particularly if it's only been there a couple of weeks, by just removing the catheter, explain to the patient that they may have a couple of accidents, but just get rid of it, or we can use flip flow valves. Have you used flip flow valves before? These are valves that you just put on the end of the catheter where the bag was attached, and it's just like a tap. So you can close the tap, people get the sensation of having a full bladder, and then they can open the tap and release the urine, and then again they can close the tap, get a sensation of, and as they regain that sensation of holding urine in their bladder, when they take the catheter out, they should get that sensation back, which they may not have had for a number of weeks or months. Okay? Fecal incontinence and constipation. One of the biggest concerns of a lot of people, particularly elderly people, is their bowels and whether they're constipated and whether things are working or not. So incontinence, fecal incontinence and constipation are again a big problem in our group of patients, in stroke patients. About a third, 20 to 40% of patients who are going to come in incontinent. The vast majority will regain continence, but some will continue to have incontinence. Constipation is most commonly associated with the fact that people are immobile, they're not eating as well as or what they used to, and they're certainly not taking the fluid that they used to, so that can cause constipation. And also things like constipating analgesics that we give, things like codeine. A day of codeine can make somebody constipated, so things to bear in mind. Associated more with frontal lobe lesions, and if someone's going to be persistent in fecal incontinence, it's more likely associated with cognitive impairment or behavioural impairment, which might be associated with a stroke in the frontal area of the brain. The important thing to bear in mind is that diarrhea isn't always associated with somebody who's on a feed. If someone's got a PEG tube or a nasogastric tube, diarrhea isn't always associated with that. Very often it's associated with more like an infective cause or something that they've taken, rather than the fact that they're on a nasogastric feed or a PEG feed. Because normally we give a bulking agent or we'd give a high fibre feed to reduce that risk of diarrhea. Assessment is really important to monitor fluid and food intake, the frequency and consistency of stools. They may need an abdominal x-ray to see if there's any fecal impaction there. We may need to take a culture if it's diarrhea and loose, and maybe need to do a rectal examination just to see what sort of stool there is. Are you familiar with the Bristol stool chart? This is a really useful chart, and what it does is it gives us an idea of what different stools mean. The top two, if you can imagine, they're almost like Maltesers almost. You know that's almost like the poo of a rabbit, almost like rabbit poo. You get very small, like pebbly type things, and then the one below it, which is sausage-shaped but knobbly, it's associated with a constipation, with a constipated stool, so quite dry. The next two down, the two sausage-shaped ones, are the normal type of stools, and then the bottom two, which is the soft, blobby one, fluffy pieces that tend to almost have a froth on them, and then pure liquid are associated with diarrhea. So it's quite useful to be familiar with the different types of stools, so you can associate them with different types of constipation, diarrhea or normal stool. The prognosis, if you continue with fecal diarrhea, is really poor. There was an American study a few years ago which looked at about 1,000 patients, and after 6 months, 2/3 of that 1,000 patients were dead. Unfortunately, they died. Now, it wasn't necessarily associated with the fact that they were fecal incontinent. It's associated with the severity of their stroke. So somebody with a more severe stroke, more likely to die at 6 months, more likely to be fecally incontinent. So of the third that remained, 1/3 of those people continued to be incontinent, 1/3 were occasionally incontinent, and only 12%, or 115, so only 115 of the original 935 had regained continence. So a long-term fecal incontinence after stroke is again a poor prognostic indicator, and there's a higher increase of morbidity, so somebody who's going to be disabled, and mortality, so somebody who's going to be dead. It's a crucial factor when we're looking at discharging somebody or where someone's going to be discharged to. Obviously, somebody who's fecally incontinent, it's a bit smelly, it's not very pleasant, it's a bit dirty. For a carer looking after a spouse or a father or mother at home, it's not a very pleasant thing to be doing. So very often, fecal incontinence will have an impact on where someone is returned to. Okay. If it isn't associated, as I said, with cognitive problems, with behavioural or thinking problems, then it's almost always remediable. So we can almost always improve it. And the sorts of things that we do is particularly in the acute phase, so when somebody first comes into hospital, is make sure someone's got adequate fluids and adequate nutrition. Okay, if you bear in mind that somebody may have had their stroke in the middle of the night, they may not have had a drink since 8 o'clock the previous evening, they arrive in hospital at 8 o'clock in the morning, so that's already 12 hours without a drink. By the time they've gone through A&E and they've had their 4 hours in A&E, gone for a CT, arrived on the ward, been clerked in, it may well be 18 hours since they've had a drink. So it's really important to maintain hydration from a very early stage after stroke, and also adequate nutrition. So as soon as somebody can eat, it's important that they get some food. Obviously, use of communication tools for somebody who can't communicate, and just a picture board with different signs on it, whether it's a male urinal or whether it's a picture of a toilet, really important. Privacy is really important. You can imagine on a ward like we have upstairs with the curtains, having your bowels open is a bit smelly and it can be a bit noisy. So privacy is essential. It's really difficult to do it behind the curtains. So if somebody can go to the toilet, I'd really encourage you to let them go to the toilet rather than sit on a commode behind curtains. Position is another thing. It's really difficult to have your bowels open if you're lying down. So if you imagine a stroke patient who's maybe got a weakness, lying down on a bedpan, it's really difficult to go to the toilet. There is an element of gravity that helps, and so if somebody's lying on their back, it's a really tricky way of going to the toilet. For a start, it's not very private, it's not very dignified, and the position doesn't help. And the other thing is feet. Feet always on the floor where possible. It's really difficult, I don't know if you've ever tried it, it's really difficult to have your bowels open with your legs dangling. So feet firm on the floor or on something will really help somebody have their bowels open, okay? Just little things to bear in mind. We can use laxatives to help, and suppositories to help with constipation. And if somebody has an incontinence, the different things that we can use to manage it are things like the constipating analgesics, so we can actually constipate somebody with something like a small dose of codeine, and then every 3 or 4 days unbung them with a suppository. So that's one way of managing it. Or I've successfully bowel trained people, and you can successfully train people to go at a specific time of day. I had a patient who had a quite devastating stroke but was determined to get home, and so we had to retrain his bowel habits. He'd go at 2 in the morning, 4 in the afternoon, 8 o'clock in the morning, and so obviously being at home without 24-hour care, it would be impossible for his wife to manage. So we managed to train him to go to the toilet on a specific trigger, and they had an Arga at home with a whistle kettle, and so every time in the morning he heard the whistle kettle going when his wife was making a cup of tea. That's when he got the urge to go, because we taught him the sacral reflex to react to the sound of a whistle in the morning, and that's the time that the carers were coming so they could help him go to the toilet. And for the rest of the day his wife used an electric kettle rather than the whistle, but we managed to train that. So really, in conclusion, just wanted to highlight the incidence of both urinary and fecal incontinence, but also the fact that most people who do come in initially recover within the first few days of stroke, but unfortunately those who go on to suffer long-term with incontinence are at increased risk of greater disability and increased risk of death, unfortunately, because of the size of the stroke. But there are very successful ways in which we can manage it and prevent incontinence, but also treat people who are incontinent.